we're going to go over to YouTube Live, and we'll let everybody on Facebook know where we are.
Cool. Backup plan. I didn't even know about YouTube Live.
All right. Okay. Hi, everybody. Let me play on. Hi, everybody. Welcome to EFTX Summer School. This is our first session. We'll be meeting every Wednesday at 6:30 p.m. and having different topics. Today, we are beginning our sessions with psychogenic non-epileptic seizures. But this summer, you have topics to look for: vacationing with epilepsy, art therapy, genetics in epilepsy. So there's a lot to come this summer. So we hope that you join us every Wednesday at 6:30. Like I said, today we're talking about PNES 101. And really, these are seizures that sometimes people get diagnosed with and they're shocked, and we get called about it. And, there's sometimes people are distraught and they don't know what to do. And we really just, want to care for you and talk you through it. And that's why we called Dr. DeLay up and said, please come talk today and help us explain about psychogenic non-epileptic seizures. Dr. DeLay is a neuropsychiatrist at Houston Methodist Hospital here in the Med Center. And he's been with us for a long time, has done a lot of talks with us, and we are so happy to have him with us again. So I'm going to turn it over to you, Dr. DeLay, for this presentation. If you have any questions, if you're on Zoom, you can put them in the Q&A down at the bottom. You'll see Q&A, and you can put them there. If you're on YouTube, you can put them in the comment section, and we will get to them there as well. So Dr. DeLay, it's all yours.
Thank you, Rebecca. So I'm going to talk about psychogenic non-epileptic seizures. There's many different types of seizures, and of course, this is one of them. So here's my outline. So first, I'm going to talk about, I'm going to define a few things, and then I'm going to talk about a couple of diagnostic criteria. The International League Against Epilepsy in the last 8 to 10 years had made a concerted effort to better define what psychogenic non-epileptic seizures were at different levels of certainty, which has been more helpful. Then I'm going to talk about the prevalence of psychogenic non-epileptic seizures, theories about the causes of those seizures, co-occurring problems. I spend a lot of time helping people with co-occurring difficulties in people with and without epileptic seizures. In fact, that was the first thing I did in Cincinnati. I'll try not to get off topic, but in Cincinnati, when I first started seeing people at a specialty center there, there was about a third of the individuals there who had non-epileptic seizures, and they didn't have a system. So I started learning different ways to help people who had psychogenic non-epileptic seizures but couldn't be helped by the treatment regimen for epileptic seizures with their memory, their emotion. And so we'll talk about those things. And then I'll talk about some basic treatment options. I can say that I've helped 6 people with psychogenic non-epileptic seizures in this particular treatment regimen that it's an eclectic approach, it's called. I took various approaches from different groups, and but I'm going to talk about the various strategies to help with psychogenic non-epileptic seizures. All right, so first off, let's talk about the textbook definition. So like epileptic seizures, psychogenic non-epileptic seizures present as paroxysmal, time-limited alterations in motor, sensory, autonomic, or cognitive signs and symptoms. But unlike epilepsy, these events are not caused by ictal epileptiform activity. So it's very, very textbook. And there's a lot of different words in there to define. I'm going to give you a different definition that I'll expand upon in just a moment. I fought with whether or not, I don't know how big your screens are. If you're on your phone, this is really terrible. You can't see any of this. But there's so many of these tables in textbooks, in research papers talking about differences between psychogenic, non-epileptic seizures and epileptic seizures, talking about what's called semiology, which means, how someone presents. And a lot of research has been done to try to look at an event and try to say whether or not it's epileptic or psychogenic non-epileptic, from incontinence to motor activities. I think the take-home message, and we'll talk about the definition of psychogenic non-epileptic seizures in a moment. The take-home message is, while this is useful in showing trends, these tables such as this are often not helpful because these are general trends. So you see it says epileptic seizures up there in the upper right-hand corner, but really there are so many different types of epileptic seizures. And it's more commonly known then that frontal lobe epilepsy has some overlapping semiology with psychogenic non-epileptic seizures. So while it's helpful generally, really it's EEG and having an event or a video of the event so that a professional can look at it. Here's another definition. So psychogenic non-epileptic seizures are events resembling epileptic seizures, but caused by psychological processes. Of course, epileptic seizures are caused by an abnormal brain electrical activity. And so there's an electrical storm in the brain for epileptic seizures, but not in psychogenic non-epileptic seizures. So what does psychological processes mean? They refer to perceptions, and we'll talk a little bit about what I mean by perceptions, one of my favorite topics. We'll talk about, and then there's cognition, so learning, memory, attention, thinking, motivation. So I taught a couple of semesters in graduate school of motivation, what motivates us. Sometimes we're motivated by things and we don't even know it. For example, when you're thirsty, you get up, you go get a glass of water. So is it you consciously doing these activities, or is it there's some underlying reason that leads us to these behaviors? That's motivation, is a psychological process. And then emotions. Perception, I can't read it here. I didn't memorize it. Here it is. I fixed it. Perceptions are very individualized. This is an important point because they're often based on life experiences and context, situation to situation. And that's an important point because some people with a history of problems don't get psychogenic non-epileptic seizures and others do. So what life experiences and what current experiences tip the balance to then all of a sudden going to a psychogenic non-epileptic seizure event? And so I wanted to guide you through this exercise of perception. So people have different perceptions with experience. So you all can't talk to me, but talk to each other. What do you see? The younger or the older woman? And so the younger woman, her nose is to the far left. It's really teeny. And we're looking at the back of her hair and her head. She's wearing a necklace. That's a bonnet on her head. You can't see her eyes. The older woman, her mouth is the necklace, and the younger woman, you can see her eye. Her eye is the younger woman's ear. Some people have trouble seeing the younger woman or the older woman. You're sitting there shaking your head, trying to find the other one, and all of a sudden it shows up. This is perception. Some research tries to show that younger people will see the younger woman, older people see the older woman. I couldn't find the younger woman forever when I saw this at 22. I think I was junior in college. And so I think that's malarkey. But anyway, this is perception. I've got another one for you here. So different people have different perceptions of experience. Here's the next one. Okay, so pick out the smaller circle. So one of these circles is smaller, right? Which one is the smaller circle? The one on the left or the one on the right? Of course, the smaller circle is the one on the left. Or is it? They're exactly the same. So what this says is, if you're a small person and you're driving a big truck, you're going to look like a smaller person. if you're a linebacker and you're driving a gas efficient electric car, you're going to look like even more giant as a linebacker. Anyway, perception matters. And that's what this shows. I think perception is an important point because people with psychogenic non-epileptic seizures, sometimes treatment involves participating in something called cognitive behavioral therapy. And so cognitive behavioral therapy looks at someone's thoughts, their feelings, and then they try to help people manage their self-talk. If someone's self-talk is what's called distorted, or they have what's called cognitive distortions, sometimes the self-talk and changing around people's perceptions can really help. And so I wanted to let you know, as you might have already known, that perceptions can differ, and reality sometimes is not real. So let's talk about diagnostic criteria. So the International League Against Epilepsy, they formed a non-epileptic seizure task force, and this was a summary of their levels of certainty. And so I've highlighted it, or I've circled it in red on here in a square on the left, or a rectangle on the left. There's different levels of certainty. We've got possible, probable, clinically established, and documented. And these levels of certainty are in a diagnosis are based on two things: being able to see a typical psychogenic non-epileptic seizure, and the gold standard brainwave activity when connected to an EEG. There's just too much here to talk about all of it, but I'm going to talk about, say, clinically established. So here, in clinically established diagnosis of psychogenic non-epileptic seizure, so a clinician, usually a neurologist here in the United States, has seen on video or in person a typical psychogenic non-epileptic seizure. And it's confirmed that, the patient may watch it on video EEG monitoring and say, yeah, that's a typical event. And then the EEG is looked at for spike waveform activity, for other types of waveform activity during this typical event. And then the epileptologist will say, hey, there's no event consistent with a epileptic seizure, and that'll be clinically established. Going up to possible, so it's witnessed by somebody, they describe it, but they got an EEG and there was no interictal activity. That's a decreased level of certainty when the epileptologist, for example, hasn't been able to see the event. So that's the International League Against Epilepsy's diagnostic criteria. It's an international consortium or group of individuals trying to standardize this across the world. There's also, so that's neurology. Often neuropsychiatrists or psychiatrists are trying to categorize these psychogenic non-epileptic seizures, and they'll use this DSM criteria for what's called a conversion disorder. With DSM-5, they're also calling it functional neurologic symptom disorder. So a conversion disorder is not, it almost still feels like a derogatory term. Let me just say, often a conversion disorder the standard is that people are not doing this on purpose. They're not doing this on purpose. That's usually what a conversion disorder is. And the word conversion suggests that someone is converting psychological distress into physical symptoms. No one does it on purpose. It's an important point. But the criteria would be that, so there's some altered sensory or motor movement that has no EEG correlate, that a neurologist most of the time says is not typical of a particular neurologic disorder, is not explained by other things. So in psychogenic non-epileptic seizures, you have to rule out other things like syncope. You have to rule out other altered consciousness issues, such as heart issues. So it couldn't be explained by those or some kind of other psychiatric disorder. And then the most important thing here in the DSM is that these medical problems have to affect someone's daily life. So if someone has these issues, but it's not impairing their ability to go to work, their social interactions, their ability to leave the house, if these things are these issues are very devastating. But DSM made this criteria where it has to be necessitating medical attention. And of course, if they're at the neurologist or at the psychiatrist, then of course it's already met that threshold, at least seeking more medical attention. So that's DSM criteria. But here's what you, if you've been diagnosed with psychogenic non-epileptic seizures, here's what you hear. I've seen this over and over again, and I'm not picking on neurologists or psychiatrists or psychologists. But what happens is you go to a particular clinic and they're looking for epileptic seizures. And so when they don't find the epileptic seizures, they say, you should be happy. You don't have epileptic seizures. You have what we call psychogenic non-epileptic seizures. And there's no happiness about it, of course. But what the patient hears, in my opinion, and what often happens is the person hears, oh, so you're telling me it's in my head. And so you're punting to a psychiatrist or psychologist. So then I will see the person, and already they feel like they've done something wrong, and you've done nothing wrong. I'm happy that you went to go see the doctor for these difficult events. But then I'm working through this difficulty where the person is believing sometimes that it's in their head. So I wanted to say, and I'm going to show this to you later when I show you how stress affects cognition, that psychological processes are biological processes. Of course they are. There's no difference between organic and inorganic, as they used to talk about in the 80s, 70s, and 80s. We've done away with organic and inorganic. Everything might be in our mind, in our head, but that's because every action, me talking, me moving, me blinking, all of that is a biological process. And so as you're listening to me right now, that's why we call it psychological. It's all our brain firing neurons in a biological process. Let's talk about the prevalence of psychogenic non-epileptic seizures. It's incredible. When I was making this slide, just incredible the number of people who may have psychogenic non-epileptic seizures. Before I do that, I'd like to say the prevalence actually isn't well known. I'm going to talk mostly about the United States, but there's numbers for different countries, especially a part of this in this International League Against Epilepsy Consortium, with people from with neurologists and others from around the world. It's not well known because the diagnosis is often tentative. People, and I'm not picking on anyone, people will go from doctor to doctor, for example, to find a different diagnosis. Some people will be treated for years for epileptic seizures. And so they get put in the category of epileptic seizures, but they have psychogenic non-epileptic seizures. In one case, I saw the numbers up to 25%. I couldn't believe 25, 1 in 4 people. That just doesn't seem right, but that's what this study said. So let's look at the numbers. 2 to 33 people per 100,000 in the United States have psychogenic non-epileptic seizures. I really can't wrap my head around that number. What does that number mean? I don't think I've except for I got a freshman at Texas A&M. So for at an A&M game, I guess I could look over and see there's 33 people right there. Okay, so that's 33 in 100,000. But when you look at the numbers compared to the whole population in the United States, 300,000 to 400,000 may suffer from psychogenic non-epileptic seizures in the United States. I've mainly worked for epilepsy specialty centers, first in Cincinnati, then at the Baylor College of Medicine when I was training, and then now here at Houston Methodist with Dr. Verma and Dr. Ma, neurologists there. And so I've seen that almost 1 in 3 people who present at the epilepsy specialty centers, between 20 to 40% in the ratings here, have psychogenic non-epileptic seizures. Some epilepsy treatment centers are well equipped to help people after they've been given the non-epileptic seizure diagnosis. Others are not. And often, like I said, people will feel like they're being punted off to the psychologist and the psychiatrist. But as I'll show you, that can be a standard of care. I collaborate with friends at the Cleveland Clinic from graduate school, and they have their own neuropsychiatrists who only see people with epilepsy and psychogenic non-epileptic seizures. That is just awesome. But they see hundreds and hundreds of, maybe even thousands, about 200, 300 brain surgeries there at Cleveland Clinic a year. But to have your own psychiatrist there to help people, that's incredible. And that would be, that's because they have the volume that they're able to do that. Otherwise, you're going to find out, if you didn't already find out, it's really hard to find a neuropsychiatrist or a neuropsychologist or a psychologist who's going to help you with your non-epileptic seizures, psychogenic non-epileptic seizures. About 10% of patients with epilepsy have psychogenic non-epileptic seizures. That's maddening, isn't it? So, it's tough enough with epilepsy or with non-epileptic seizures, but then having both is incredibly difficult. The age range is most common for first onset in someone's 20s and 30s. And there are case studies talking about diagnosing a first psychogenic non-epileptic seizure as young as 3 years old. I've seen a few older adults who have been diagnosed new onset psychogenic non-epileptic seizures. And the literature talks about 10% of people with psychogenic non-epileptic seizures as also having an intellectual developmental disability. So going deeper into different characteristics, gender is often talked about. I often hear more women have psychogenic non-epileptic seizures than men, but there's a caveat. That's absolutely not true. It is true in people, I almost said the middle ages, but 18-year-olds, just a teenager still. Between the age 18 to 50s, those ages, sure, it's 3 and 4 men, but there are no gender differences in kids, no gender differences in older adults. And in fact, there are more males with psychogenic non-epileptic seizures with an intellectual disability. I think often, it can be derogatory to say it's one or the other when we're dealing with women with psychogenic non-epileptic seizures between the ages of 18 to 50. I try to be a blank slate because that means there's 25% of men that are also having this, a blank slate, and not try to presuppose that it has anything to do with being a woman or a man. It just happens that maybe it's that women go to the doctor more. I see that, absolutely, in those ages. That's not founded scientifically, though. That's my opinion. All right, let's talk about theories about causes of psychogenic non-epileptic seizures. There are so many different models, and I am going to get a little technical. I'd rather be more user-friendly, but I'm going to get a little more technical with these models. I tried to find a bigger picture. If you're looking at this on your phone, I apologize. Some of these words are going to be kind of small. Let's see here. So first, I want to talk about the different risk factors in these models. So different associations. These aren't causes. These are associations. So people with psychogenic non-epileptic seizures can have a history of depression, post-traumatic stress disorder, physical, emotional, sexual abuse, family stressors or conflict currently or in the past, attentional issues, personality disorders. What I didn't do is I didn't line up the percentages that can happen in epileptic seizures. So there are plenty of tables that talk about people with epileptic seizures having some of these things also. But these, I'm specifically talking about psychogenic today. These are risk factors. The last line says, though, but plenty of people with these problems, with psychosis, personality disorders, ADHD, for example, plenty of these people in those individual categories never get psychogenic non-epileptic seizures, right? So in and of themselves, these things do not suggest that you're going to get psychogenic non-epileptic seizures later in life. I like this model from Ruber that talks about 3 different things. It talks about predisposing factors. So what happened in the past before you had your first event, or what you cannot control, like a genetic predisposition. So predisposing factors, it talks about precipitating factors, which I'll show you in a minute. You know, what was happening at the time of, near the time of the first psychogenic event? What were the risks that at that moment? And then perpetuating factors, which means, you know, why do some people persist in their events and they can't be controlled and they don't go away? And why do others get them well controlled? Before I talk about this model, it comes to mind that I think for me, one of the best predictors in helping these 6 people that I had helped before in my career was that if I got someone early after the diagnosis of psychogenic non-epileptic seizures, I could help them to a greater degree. It was the individuals that had been living them with even a year and a half, 2 years, and then they found me, or I started interacting with them. It was just the way that they had learned how to deal with the events, and not their fault. It was harder to help retrain them to find ways. And they in their mind, they were thinking, oh, they keep saying it's in my head. And that's absolutely not true, if you believe that psychological processes are perceptions and that they're biological. Okay, let's go to predisposing factors. So early experience, abuse, neglect, genetic predisposition, and the interacting with later experiences in life, interpersonal problems, or stressors. And let me say one caveat here, that I was very annoyed early on in my career with the high emphasis on childhood abuse or neglect as a risk factor. And I'll show you later, it doesn't happen in everybody, because it was always, oh, this person has neglect. This person has a history of physical, sexual, or emotional abuse. Oh, so they're predisposed to have psychogenic non-epileptic seizures. Like I said, there's plenty of people who have had those and they don't get psychogenic seizures. There are people with epileptic seizures who have had these difficult childhood or adult experiences, and they don't get non-epileptic, or they do get epileptic. So while it is a predictor, it doesn't happen in everybody. That's predisposing years before, months before the psychogenic non-epileptic event. Then precipitating factors, let's just say within a month, a week, a year, stressful life experiences, conflicts in relationship. This is a very negative model, isn't it? But it is what it is. Dilemmas, being in a job that you hate with an angry boss, or with a stressful boss, in a job that you don't find meaningful. That happens often. Interacting with a history of issues, and interacting with maybe new medical issues, a bad knee, pain from that, COP, breathing issues, or depression and anxiety. So those things are precipitating factors. And then bam, out of nowhere, this first event leading you to the emergency room, leading you then to a follow-up with a neurologist, or your family physician. So these are the predisposing factors. And in this model, Ruber's model, then Ruber talks about then, what perpetuates, why does this event continue? For some people, it doesn't continue. There's one event, it doesn't have, one person had an event and then didn't have another event for 3 to 6 months. Other people then start getting treated for epilepsy. Other people then, get treated for psychogenic non-epileptic seizures. So the perpetuating events would be avoiding, so not leaving the house. The event happens and they find an unhealthy way to manage the event. Isolation, increase in stress. Of course, these things are terrible. Anger and anxiety, depression, and then attributing. So maybe something happened just before, a loss in life, something, and then people will start to attribute this event to other, to particular things. Some people carry on a sick role. Other people don't carry on a sick role, meaning that, some people will go to work, they'll take care of their different roles in their lives, and other people are very disabled by psychogenic non-epileptic seizures. And then, of course, I talked about misdiagnosis and mistreatment. I've met plenty of people who were on epileptic medications, anti-epileptic medications, who did not, it looked like they did not have epileptic seizures. So this is Ruber's model. Briefly, then let's talk about this issue of abuse. And so it actually varies, and I'm talking about physical, sexual, or verbal abuse. The type of abuse in people's history for psychogenic non-epileptic seizures, and I apologize, I wish we could be in one place. This is such a difficult topic to talk about. It may bring up experiences, from a long time ago, and I apologize, but it is an important thing to talk about because there's misconceptions. So this thing about physical, sexual, or verbal abuse predicting psychogenic non-epileptic seizures, sure, in adults in that age range, to 18 and 50, sometimes the rate is between 40 to 70%. Here it is 75%. But in the study that reported 40%, that means more than half the people in their study did not have physical, sexual, or verbal abuse. I think that's such an important point. Prediction using abuse as a prediction in kids is different, because the precipitating or perpetuating factors in kids, it's less about those types of abuse and more about fears at school phobias, and difficulties in school, such as bullying, trouble learning, those kinds of things. And in older adults, it's less about the history of abuse and more about later in life. Sometimes there's health-related traumatic experiences. Met someone who started having them at the age of 65 years old. And then I jumped into the literature. It was unheard of for me. Fewer individuals with an intellectual, developmental disability had a history of abuse in their studies. Again, the take-home message, and the reason I put this slide up here, is because not everyone with psychogenic non-epileptic seizures has a history of abuse. So that's important, because then the type of psychologist that you'll see, some like to stay in the past, and I'm not picking on them. They like to stay in the past and talk about, help you process your childhood. Then they come to the current time and give you tools to help manage those issues. Others never go to childhood and stay in the here and now. And sometimes if you have unresolved issues from childhood, that might be the kind of psychologist that you might need to see. Let's talk about co-occurring problems associated with psychogenic non-epileptic seizures. So I've got 3 slides here. So one of the co-occurring problems is, of course, depression, anxiety. In this study, people with psychogenic non-epileptic seizures had high rates. Oh, I'm sorry, it's not a study, it's a review of the literature. People with psychogenic non-epileptic seizures had a high rate of comorbidity, psychiatric comorbidity. So anywhere between half to everyone in different studies had some kind of psychiatric issue. But then I like to say then in that one study talking about 53%, that meant 47% did not get a diagnosis of a particular psychiatric disorder, besides psychogenic non-epileptic seizures, which is more treated within neurology first and then psychiatry. Notably, though, in that review, post-traumatic stress disorder was more common And then there were rates of depression and there were higher rates of depression personality disorder. The interesting thing is, compared to people with epilepsy, people with psychogenic non-epileptic seizures were significantly higher in their rates of post-traumatic stress disorder, but not depression. So having depression cannot be used as a predictor of whether someone has psychogenic non-epileptic seizures or epilepsy. In this next study or review, it was talking about cognition. And I found this interesting that so memory problems are very common in people with psychogenic non-epileptic seizures and in people with epileptic seizures. While memory problems seem to be most prominent in people with epilepsy, attention and executive issues were more dominant in people with psychogenic non-epileptic seizures. That's a generalization because it depends on where the epileptic seizures are, but attention and executive issues were found to be more prevalent, at least when they were reviewing. But I wanted to say then, this is a caveat. So sometimes people will have memory problems for different reasons. So if I'm forgetful, but my hippocampus is okay, that's the part of the brain dealing with memory. Think of hippopotamus on a college campus. That's how you can remember it. So imagine a hippo on a college campus, that's a hippocampus. So if that's intact, but I'm having trouble with memory, what could it be? And usually it's because an executive function such as multitasking is impaired in someone with psychogenic non-epileptic seizures. So forgetfulness exists, but the cause is different than it would be in epilepsy, where that hippocampus may be damaged in someone with epileptic seizures, especially temporal lobe epilepsy. In this last study, I found it interesting because they looked at people with psychogenic non-epileptic seizures with and without post-traumatic stress disorder, and they found that memory problems existed to a greater degree in people with psychogenic non-epileptic seizures with PTSD compared to those without. I promised you I'd talk about how psychology equals biology, or psychological processes equals biological processes. So I use this slide regularly to help people better understand. This is from a Women's Health magazine, how stress leads to forgetfulness. So when someone says, you know, you're stressed out, that's why you're forgetful, I think I mentally filter if I heard that, and I would say, oh, so you're telling me it's in my head. So that since I'm stressed, so what do I need to just do yoga and my memory will get better? Is that what you're trying to say? Or, you know, it's in my mind. You know, I have real memory problems is what someone might say. So what's the biological mechanism? So bear with me if you will here. I'll use this cursor here. So first, chronic stress, anxiety, and depression causes forgetfulness. It's a fact. This is called the stress brain loop. So someone who is stressed out could be sleeping less, not eating very well, and they could be depressed or anxious. What that does is it changes the cortisol levels in the brain. One type of cortisol, a glucocorticoid, increases, and that can change. Glucocorticoids are important in forming new memories. It changes and creates changes in the hippocampus. So stress leads to forgetfulness through cortisol or glucocorticoids. That's a biological process. So yes, stress leads to forgetfulness, and that's because of changes in cortisol. All right, let's talk about various treatments. So I chose, there's so many different treatments, and there's no treatments at all. Let's say it that way. I found a website that, I wish I would have brought it here, but found a website that talked about, that had all 50 states, or it had states. You click on Texas, and it would show you the 6 people in the state of Texas who might provide psychotherapy for someone with psychogenic non-epileptic seizures. 6 people, and I think there's like 3,000. I don't know how many there are, psychiatrists and psychologists, thousands, but there's only 6 people who were on that website that specialized. Treatments are far and few between. I first learned about treatments when I followed this person named George Brigatano, who did a research project trying to find out if group therapy could help people with psychogenic non-epileptic seizures. He was a rehabilitation specialist, and he found that any attention is good as long as it focuses on particular ways to help people process information and then provide tools. And having a mentor or having a model or being a mentor in a group therapy setting was very therapeutic in helping people. So when you know, like here at the Epilepsy Foundation, when you know there are other people going through the things that you're going through, it's invaluable to connect to those people, to learn with them, and to know that you're not alone. Let's talk about those treatments. So I chose this slide. It's a little busy, but I like this one because the treatments that are offered depend on the goals of treatment. So in this case, what's the goal? Is the goal to accept a diagnosis? Because I think that's a very important point. If you don't accept that you have psychogenic non-epileptic seizures, not like you have to, but if you don't accept that you don't have it, then you'll continue to go from to the next practitioner, the next doctor. If it's understanding, that's participating in this presentation is helping you to better understand what these events are. Sometimes it's an educational setting like this. Sometimes in psychotherapy, I often help guide someone through the educational process. There's great handouts I don't have great handouts, but a handout for family members and for the patient. There's great ones at from the Tampa VA. If you Google psychogenic non-epileptic seizures in Tampa VA, someone did an awesome job with educational material there. Or I'm sorry, the Tampa Hospital. Control. So if the idea is to help better manage the psychogenic non-epileptic seizures, there are different validated approaches, including biofeedback, counseling, which means educational or psychoeducational settings, meditation, medication, cognitive behavioral therapy, and different relaxation techniques. So the guiding you to the particular type of treatment depends on whether you accept it, whether you want to be treated, whether you accept that you might try to be treated. You go through all of this, and still, out of those 6 people that I have helped, still, some people, it still is intractable. In all of the individuals I've helped, it's diminished. And I use some different techniques that also help people with anxiety attacks, but it's important to know that psychogenic non-epileptic seizures are not panic attacks. These are some of the treatment options. I'm going to go into this cognitive behavioral therapy approach and talk about the cognitive and the behavioral aspects of treatment for someone. This is more practical for you if you get anything practical out of this. So I often talk about these things called cognitive distortions. It's a way that I process information in my mind. And so if I have all or none thinking, I see things in black or white. Either I'm successful in helping someone or I'm a failure. There's no gray area for me. It's all or none. If I don't get first place, if I get second place, it was a waste of my time. Now that's not true, but some people think like that. There's something called overgeneralizations, where a single negative event in your life, you can't get it off your mind. It keeps you up in the middle of the night. The next day, you might still be thinking about it. There's this never-ending pattern of it stressing you out. It could be an interaction with your boss, your loved one, your siblings. And then you overgeneralize about the magnitude of that problem. There's something called a cognitive distortion called mental filtering, where you focus on the negative. I'm not saying to focus on the positive, but some people focus on the negative and dwell on it. And so they're focused on just one aspect of the bigger picture. Mind reading is a big one. So you may conclude that someone is reacting to you in a negative way. And I do this with my wife. I'm wondering if she's passive aggressive, if something happened and I'm wondering if she's got some ulterior motive. But I need to check reality sometimes, because often people aren't doing these things to me. A perfect example is someone cuts you off while you're driving. You put yourself in the person's place. You think they're a terrible person, they're a terrible driver. You take it personal, for example. There's many cognitive distortions. I talk about 10 usually. The idea in cognitive behavioral therapy is to help untwist these distortions in more healthy ways, to teach you positive self-talk. How is this important in the whole scheme of psychogenic non-epileptic seizures? Sometimes unhealthy cognitive distortions can perpetuate some of the events that happen. Of course, the fear of dying is a big deal, and you can get post-traumatic stress just from that. But you survive it. It's not the end of the world for most people, right? And so you can get through that. Using a cognitive behavioral therapist, you can learn about cognitive distortions and ways to untwist thinking. And then there's the behavioral aspect of it. So sensory grounding, which I'll show you here to the right, relaxation techniques, and abdominal breathing. I use what's called 4-4-4, which is 4 seconds breathing in, 4 seconds holding it, 4 seconds blowing out. When I'm stressed, that holding it feels so good. I often use that in myself just to catch my breath so I don't stick my foot in my mouth. The understanding your triggers. Sometimes there's just no way to figure out what triggers are. In fact, many people never really figure out what led to the psychogenic non-epileptic seizures, but being your own scientist can often help look for cause and effect. Trying to not be isolated, that's a behavioral approach where you try to remain social. Often you don't want to have an event in public at the grocery store where you had it, right? And so you may start to not leave your house, and that's a tough thing. And then delegating and saying no. So I've used up a lot of time here. I want to quickly say, for sensory grounding, what I would do usually with a person is I'd have them, if they were starting to have an event, once they were able to focus, I would have them grab their wrist and focus on the touch of their wrist, or look at their hand, or look at the hairs on their hand. There are many. Sensory grounding is referring to finding smell, taste, touch, sight, hearing, finding a sense and focusing on that sense. Smelling something like lavender, focusing on, like I said, your wrist. So you're always with your wrist. That's why I recommended a body part. Breathing techniques, they recommend the 4-7-8. So I don't know if I created the 4-4-4, but I have no patience to hold my breath for 7 seconds and then blow it out for 8 seconds. But there it is, the 4-7-8. So focus on your breathing. This is one behavior management approach to helping psychogenic non-epileptic seizures. And you do this alongside a healthcare professional. Okay, I think your brains are full. We have time for questions, hopefully.
Okay, let me my video back on here. So let's see you. All right, great. So one of the questions was, can you have psychogenic non-epileptic seizures along with epileptic seizures?
Right. So you've seen the slide now that talks about approximately 10% of people have both. What I didn't emphasize today is because, I often don't want to give false hope for people, but I've met one person who was found to have epileptic seizures after 10 years of EEG, and they were treated for psychogenic non-epileptic seizures when they had both. And so it can happen. And that's mainly because it's hard to capture these events, an epileptic seizure on video EEG anyway. So good question.
I was in a presentation like this with Dr. Chen from the VA. He has passed away since, but he gave a great presentation just like this one, and he showed us videos of he had us guess which seizure was a epileptic seizure and non-epileptic seizure, and we all guessed wrong on all of them. Even for us, for staff who have seen seizures, for a number of years now.
And that's right, exactly right. That's why I was saying those tables are sometimes not helpful. That's why the gold standard is the EEG. I love that. I'm going to steal that.
Yeah, it was great. I mean, it's stuck in my memory forever. Okay,
Right.
let me go down here. Dr. Gupta asked, how sensitive are serum, prolactin, and video EEG in PNES?
Right. So they use serum prolactin to try to differentiate. There are different numbers, right? Talking about sensitivity and specificity. So, for serum prolactin, I don't know the exact numbers. I didn't bring them up. As a cursory review of it. And we don't do it as a standard here. But video EEG monitoring, once you capture the event, it's 100%, right? It's video, of course, video EEG monitoring is the gold standard. The problem is many countries, just people don't have access to the video EEG monitoring. And then you have EEG, and then you have to rely on the person. But I apologize. I don't know the prolactin. It's a great question. I was trying to make this not as technical, Dr. Gupta.
He says, thank you. Okay, I have another question. Thank you for your question, Dr. Gupta. Hold on, let me read it. Are non-epileptic seizures treated with the same type of seizure medications?
Right, so and we're talking about psychogenic non-epileptic seizures. So I've met plenty of people, so many people. In fact, most of the people who came to the University of Cincinnati epilepsy monitoring unit were on epileptic medicines, and that was 1 in 3 were on epileptic medicines. And physicians are tentative about taking people off of epileptic medicines. This was 1999 when I first started working there as a student. So the treatment, the medications are started there, but once we can have a more definitive diagnosis of psychogenic non-epileptic seizures, then people are routinely taken off of those medicines. I'm sorry, not routinely. They might leave them on one medicine. Some people are put on 2 or 3. There's a fear of taking them off, but in good centers, if they have enough confidence, they take the people off the medicines because they can do more harm than good for someone who shouldn't be on them.
Great. I think that is all the questions, just making sure over here. Yes, that's all the questions. I think that you really hit the nail on the head when you talked about acceptance. Some of the videos that I've seen where people have gone in for treatment for psychogenic non-epileptic seizures, and they accepted it and went into the program for however long it was. Just the change that they've had is amazing. And with people like you and we're here, and I think it's finally coming around where people are starting to not say those things like it's fake, or it used to be called pseudo seizures, right? And that's just finally starting to fade away now. And so these are real things that are happening to people, and we just want to care for them and help them find the right help that they need. So thank you for talking about this with us today.
Thank you, and thank you, everybody.
Thanks, everybody. Next week, we will be back again at 6:30. Hopefully Facebook will not be having problems then, but we will be talking about vacationing with epilepsy, and talking about what you need to take with you, what papers, what happens if you're in the emergency room. Oh, we had one more hand raised. Just making sure.
I think there's a new one there.
So the excellent presentation was the hand raise, so that's great. What happens if you end up in the emergency room overseas or in a different state. So it should be a great presentation, and we'll see you next week at 6:30. Thank you, Dr. DeLay. Thank you, everybody.
Bye. Thank you.